Hello viewers, I am Dr. Robiul. I work as a lecturer in pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is inflammation part 1. Since inflammation is a very big topic, so I will try to upload videos about inflammation part by part. In part 1 of this series, we will try to define inflammation, then discuss the components of inflammation, the goal of inflammation, the causes of inflammation, some historical highlights. We will also try to classify inflammation and mention the differences between acute and chronic inflammation, followed by a brief discussion on the vascular events of inflammation. In part 2, that I will hopefully upload within a week, we will talk about the cellular events of inflammation and different chemical mediators of inflammation. And in the third part of this series, we will discuss about chronic inflammation. Okay, so a lot of topics, so let's begin. First question, what is inflammation? How can we define inflammation? Now, in your textbook, you will see a very big definition of inflammation, but don't get scared because I will explain this definition line by line afterwards. So, inflammation can be defined as a response of vascularized tissues to infections and damaged tissues that brings cells and molecules of host defense from the circulation to the sites where they are needed in order to eliminate the offending agents. Okay, so I hope you are still with me. You didn't run away just like my students do when I try to teach them definitions. I even have to show them teddy bear to keep them calm. So look, I am also showing you a teddy to keep you calm. And now I will explain this definition line by line. So what did we see in the first line of the definition? Inflammation is a response of vascularized tissues. Now note the word vascularized. That means inflammation will happen in those tissues that have their blood supply. In another word, inflammation won't occur in avascular tissues or tissues that doesn't have blood supply. So always keep that thing in your mind, that inflammation is a response that will happen in vascularized tissues. And this response will happen against what? It will happen against infections and damaged tissues. And what will happen during this response? Cells and molecules of host defense will migrate out of the circulation and they will go to the site of infection or to the site of damaged tissue. Why? Why will they go there? They will go there to eliminate the offending agents. So, from the above definition, it is clear that inflammation is actually a protective reaction that is essential for survival. However, inflammation can become harmful when the inflammation is misdirected, either against self-tissue that will result in autoimmune diseases or against normally harmless environmental substances that will result in hypersensitivity and allergy. And also chronic inflammation can result in a lot of chronic diseases, say for example rheumatoid arthritis, hypersensitivity, atherosclerosis, lung fibrosis, etc. So these are the harmful consequences of inflammation. So now that we have defined inflammation and also talked about some of its harmful consequences, now let's move on to the next point, and that was the components of inflammatory response. So the main components of inflammation include blood vessels and leukocytes. And we will see from our later discussion that during inflammation, blood vessels will dilate and that will slow down the blood flow, which is also known as stasis. And also there will be some alteration in the permeability of the blood vessel. The blood vessels will become highly permeable, and that will cause migration of circulating proteins to the sites of infection or tissue damage. So one component of inflammation is blood vessel, and sometimes the examiner may want you to elaborate the components of blood vessel. Then you have to say the different parts of blood vessel, say for example about the endothelial lining of the blood vessel. You may also have to talk about the basement membrane and even extravascular tissue. Moving on to the second component of inflammation, and that was leukocytes. And as we will see later, different types of leukocytes are involved in different types of inflammation. Say for example, in acute inflammation, polymorphonuclear leukocyte or neutrophils play the major role, whereas in chronic inflammation, lymphocyte, plasma cell, monocyte, they play the predominant role. So the leukocytes will first come to a halt, and then they will get out of the circulation and migrate to the site of injury or to the site of infection. Once they have recruited to the site of injury or to the site of infection, the leukocytes will get activated, and then they will ingest and destroy the harmful microorganism and dead cell, as well as different unwanted materials and foreign bodies. So these were the two major components of inflammation. If the examiner asks you about them, always remember they are the blood vessels and the leukocytes, and you may have to elaborate different parts of a blood vessel if the examiner asks. So now that we have talked about the different components of inflammation, now we will move on and talk about the goals of inflammation. There are two major goals of inflammation. The first one is to get rid of the initial cause of cell injury. The initial cause of cell injury may be some microorganism or some toxins. The second goal is to get rid of the consequences of such injury. Say for example, after an infection or due to some toxins, tissue and cells can get damaged and necrosed. So the second goal of inflammation will be to get rid of those necrotic cells and tissues. Now in your exam, the examiner often will ask you what will happen if inflammation did not take place, and then you have to say that if inflammation didn't take place, infection would have gone unchecked, wounds would never heal, and injuries might have remained as permanent festering sores, as written in your textbook. And the examiners are very fond of these three lines. So always remember, if there is no inflammation, there would have been infection, persistent infection, that is, infections would have gone unchecked, wounds would have never healed, as we will discuss during our chronic inflammation video, that wound healing and inflammation are closely interlinked. So if there was no inflammation, there would have been no wound healing as well. And also injured tissue might remain as permanent festering sores. So now we will talk briefly about the historical highlights of inflammation. Always remember that inflammation has a rich history, and a lot of discoveries of the past have led to our current understanding of inflammation. Now, people knew about the clinical features of inflammation for a long time. For example, the clinical features of inflammation were found written on Egyptian papyrus that dated back around 3000 BC. So that's a long time ago, right? However, the cardinal features or cardinal signs of inflammation were first described in the 1st century AD by a Roman writer named Celsus. And the examiners are very fond of the cardinal signs of inflammation, they will often ask you what are the cardinal signs of inflammation. So first, 4 cardinal signs were listed by Celsus, and later a 5th cardinal sign was also added. So what are the 4 cardinal signs that were first listed? They are rubor or redness, calor or heat, tumor or swelling, and dolor or pain. And later another cardinal sign was added by Rudolf Virchow in the 19th century, and that was functio lisa or loss of function. Now note that one of the cardinal features I mentioned was tumor, that meant swelling. Nowadays the term tumor and neoplasia are used interchangeably. However, when we are talking about the cardinal features of inflammation and when we are saying tumor, in that case tumor meant swelling. Okay, so I'll always keep that thing in your mind, that although nowadays we use the word tumor and neoplasia interchangeably, but in the past tumor, the term or the word tumor, was also used to denote swelling. So now we just use that thing to denote swelling only in case of the cardinal features of inflammation. In everywhere else, the word tumor most of the time denotes or is used for the word neoplasia interchangeably. Then in 1793, Scottish surgeon John Hunter discovered that inflammation is not a disease, and in fact it is a response that has a lot of beneficial effect on host. Later in 1880, Russian biologist Eli Mechinkov discovered the process of phagocytosis. Now I have a separate video on phagocytosis, and you can also watch that in my channel after watching this video for more information. Later, Sir Thomas Lewis discovered the role of histamine in mediating vascular changes of inflammation, and this discovery later led to further discoveries of different chemical mediators of inflammation. So now that we have briefly talked about some historical highlights of inflammation, now we will move on and briefly discuss the causes of inflammation. So the major causes of inflammation include infections, tissue necrosis, foreign bodies, and immune reactions. So let's talk about these things one by one briefly. Now always remember, infections, either bacterial, viral, fungal, parasitic, and microbial toxins, are one of the most common causes of inflammation. Different types of cells in our body contain toll-like receptor and other cytoplasmic receptors that can detect different infectious agents. Once these infectious agents are detected by those specific receptors, that triggers some signaling pathway, and that later results in stimulation of production of different types of chemical mediators of inflammation. Regarding the second cause of inflammation, and that was tissue necrosis. Now, tissue necrosis can happen due to a variety of causes, say for example following ischemia, trauma, and after physical and chemical injury. And whatever the cause of tissue necrosis is, always remember that tissue necrosis can cause inflammation as well. Now during tissue necrosis, different types of molecules are released from the necrotic cells that can trigger inflammation. They include uric acid, that is a purine metabolite, ATP or adenosine triphosphate, that is the normal energy store of our body, and DNA binding protein of unknown function that is called HMGB1. All these things can trigger inflammation. And also remember, even DNA, when that thing is not confined in the nuclei and instead is released in the cytoplasm, that DNA in the cytoplasm can also trigger inflammation after tissue necrosis. And as hypoxia is also an important cause of cell injury and tissue necrosis, and hypoxia can also cause inflammation as well. And the idea is, whenever some cells are deprived of oxygen during hypoxia, they produce hypoxia-induced factor 1 alpha. And this factor activates the transcription of different types of genes involved in inflammation. Particularly important is the gene that produces vascular endothelial growth factor, or VEGF. And that thing later causes increased vascular permeability and promotes inflammation. Moving on to the next cause of inflammation, and that was foreign bodies. Always remember that foreign bodies like suture, splinters, dart can cause traumatic tissue injury, or they can carry different types of microorganisms, and all these things can result in inflammation. The next cause of inflammation was immune reaction, and among immune reaction, I have already mentioned that we can have two types of reaction. One is hypersensitivity reaction and the other one is autoimmune disease, and all these things can cause inflammation as well. So now that we have talked about the different causes of inflammation, now we will move on to the next topic and discuss briefly about acute and chronic inflammation. Now, what do we mean by acute inflammation? Acute inflammation is the initial rapid response against infections and damaged tissue. Therefore, acute inflammation is rapid in onset. It usually develops in minutes or in hours. And again, acute inflammation has a very short duration, lasting for several hours to few days, compared to chronic inflammation. The main feature of acute inflammation will be exudation of fluid, plasma protein, and also immigration of leukocyte, and the predominant leukocyte in acute inflammation will be neutrophils. And sometimes neutrophils are also referred as polymorphonuclear leukocytes. And you also have to remember, in most of the time when the acute inflammation fulfills its goals, that is to stop or contain the offending agent and also to remove the damaged tissue, when those things are fulfilled, usually acute inflammation subsides. However, if the acute inflammatory reaction fails to remove the offending agent, the reaction may progress to a further prolonged phase, and that is known as chronic inflammation. And you will also see in your textbook that chronic inflammation has a very good definition. Chronic inflammation is the inflammation of prolonged duration. That means it can go on for weeks or even months, during which three things are happening simultaneously. They are inflammation, tissue injury, and attempt at repair. So chronic inflammation is an inflammation of prolonged duration that is happening for weeks or months, during which inflammation, tissue injury, and attempts at repair coexist in varying combination. So now that we have talked briefly about acute and chronic inflammation, how can we differentiate between these two? So first is the onset. Obviously, acute inflammation has a rapid onset. It can develop within minutes or hours, whereas chronic inflammation has a slower onset. The second point in the difference is regarding the predominant cells. The predominant cells in acute inflammation are usually polymorphonuclear neutrophils, whereas in chronic inflammation the predominant cells are monocyte, macrophages, and lymphocyte. The next point of difference is tissue injury and fibrosis. Tissue injury and fibrosis are very mild and self-limiting in acute inflammation, and tissue injury and fibrosis are severe and progressive in chronic inflammation. And also remember that the local and systemic signs are very prominent in acute inflammation, whereas in chronic inflammation they are less prominent. And as we will see later when we talk about chronic inflammation in the third video of this series, we will see that chronic inflammation can follow acute inflammation if the acute inflammation fails to remove the offending agent. However, chronic inflammation can also begin insidiously as a low-grade response without any manifestation of acute reaction at all. So now we will move on to the next topic and begin our discussion on acute inflammation thoroughly. So acute inflammation has three major components. They are alteration in the vascular caliber, and whenever there is alteration in the vascular caliber, as we will see, there will be increase in blood flow. So that's the first major component of acute inflammation. The second major component of acute inflammation will be alteration in the microvasculature, and that will result in increased vascular permeability. And the third major component of acute inflammation will be immigration of leukocytes. The leukocytes will come out of the microcirculation and then they will move and accumulate in the focus of injury, and later they will activate to remove the offending agents. And in the first video we will talk about the first two components, that is alteration in vascular caliber and alteration in the vascular permeability, briefly. So first let's talk about alteration in vascular flow and caliber during inflammation. Now always remember, the alteration in vascular flow and caliber, they are the earliest manifestations of acute inflammation. So first there will be vasodilation in the arterioles. The vasodilation is induced by some chemical mediators. Among them notable are histamine and nitric oxide, and they act on vascular smooth muscles. Always remember that vasodilation will later lead to opening of new capillary beds in that area. So first there will be vasodilation in the arterioles, and then that will lead to opening of the new capillary beds in the area. And all these things will result in increased blood flow in the affected area, and that will cause the heat and redness of inflammation. Now remember, we had discussed earlier that inflammation had 5 cardinal signs, and 2 of them were heat or calor and redness or rubor. So now we know why heat and redness develops at the site of inflammation. They are happening as a result of increased blood flow due to the effects of chemical mediators like histamine and nitric oxide on vascular smooth muscle. Now one thing you have to remember, sometimes there may be a period of transient vasoconstriction before this vasodilation stage. So always keep that thing in your mind too, that the major change in vascular flow and caliber is vasodilation. However, sometimes there can be a transient period of vasoconstriction before the stage of vasodilation as well. Now vasodilation will be quickly followed by alteration in the vascular permeability. There will be increased vascular permeability in the microvasculature that will result in escape of protein-rich fluid from the blood vessel into the extravascular tissue. So what will be the outcome of these things? Loss of fluid and increase in the vascular diameter will cause the blood flow to become slower. The blood viscosity will increase too, because there is now less fluid inside the blood vessel. So all these things, the change in the vascular caliber, the increase in the caliber of the blood vessel, the slowing of the circulation, the increased viscosity of the blood, all these things will result in a condition that is termed stasis. And this will be seen as congestion. So remember this term stasis, because when we will talk about the cellular events of inflammation in the next video that I will hopefully upload within a week, we will see that stasis will cause leukocytes, mainly neutrophils, to accumulate along the vascular endothelium, and that will later result in rolling and adhesion steps of inflammation. So we will talk about those things in the next video. So the second major component of acute inflammation was alteration in the vascular permeability. Always remember, increased vascular permeability is the hallmark of acute inflammation. The examiners are very fond of asking this question, that what is the hallmark of acute inflammation, and then your answer should be increased vascular permeability. And whenever there is increased vascular permeability, that will result in escape of protein-rich exudate from the blood vessel into extravascular tissue, and that will cause edema. So now that we have mentioned some technical terms like edema, exudate, so I think it is better if we talk about those things first before explaining how increased vascular permeability occurs. So what do we mean by edema? Edema means accumulation of excess amount of fluid in interstitial tissue or in the serous cavities. Edema can be either transudate or exudate. So what is an exudate? An exudate is a fluid with high specific gravity that will be more than 1.020. It will also contain high protein concentration, and it will contain cellular debris. On the other hand, transudate is the exact opposite. It is a fluid with low specific gravity that will be less than 1.012. It will have low protein content, and most of that protein will be albumin, and also in a transudate there will be little or no cellular material. The process of forming an exudate is known as exudation, and the process of forming a transudate is known as transudation. So now let's talk about the different mechanisms of increased vascular permeability. The major mechanisms include contraction of the endothelial cells, endothelial injury, and transcytosis. So we will talk about these things one by one. Now always remember, the most common mechanism of increasing vascular permeability is contraction of the endothelial cell. Now in your textbook you will also see that increased vascular permeability is also referred as vascular leakage. So contraction of endothelial cell will result in increased interendothelial space. That is the space between two endothelial cells, and when the endothelial cells will contract, the space between the two endothelial cells will increase. So that increased interendothelial space will result in vascular leakage. Now this vascular leakage can be induced by some chemical mediators. They include histamine, leukotrienes, substance P, bradykinin, etc. This vascular leakage is also known as immediate transient response, because It happens very rapidly after exposure to the chemical mediators, and at the same time it is usually short-lived. It lasts only 15 to 30 minutes. Now, you must be wondering, if there is a term immediate transient response, shouldn't there be a term delayed prolonged leakage as well? And you were right. Now, what is that thing? Sometimes after a mild injury that can happen due to burn, X-ray or ultraviolet radiation, the vascular leakage doesn't happen immediately. So there is not immediate response. On the contrary, that happens after a delay. That delay can be 2 to 12 hours. And also that response doesn't finish quickly. That response is not short-lived, but lasts for several hours, sometimes even for days. That is why that response is not immediate, not transient, but that is delayed and prolonged. And that thing is known as delayed prolonged leakage. Sunburn that can sometimes appear late is a very good example of delayed prolonged leakage. The next mechanism of increased vascular permeability was endothelial injury. Now, endothelial injury can happen as a result of direct damage to the endothelium. Direct damage to the endothelium can happen in a lot of injury, say for example during burn, and also by different microorganism that targets the endothelial cell. And as we will see from our next video, that neutrophil has a key role in inflammation, and in one stage neutrophil adheres with the endothelium before it can go out of the blood vessel. And during that stage, when the neutrophil is adhering with the endothelium, sometimes it can also damage the endothelium as well, and that will also result in endothelial injury and increase vascular permeability. Most of the time, increased vascular permeability via endothelial injury starts immediately after the injury, and it persists for several hours until the damaged vessel has been repaired, or in other cases thrombosed. The next mechanism of increased vascular permeability is by increased transcytosis. Now, in order to understand the term transcytosis, first we have to know about a specific organelle that is found in the cytoplasm of endothelial cells. The name of that organelle is vesiculovascular organelle. It is located inside the cytoplasm of the endothelial cells. A lot of them are also located close to the intercellular junctions. And the function of these organelle is to act as channel. They are made up of uncoated vesicles and vacuoles that are interconnected with one another, and they help in transport of fluid and protein through the endothelial cells. Certain growth factors, say for example vascular endothelial growth factor, can promote increased vascular permeability by increasing the number and sometimes also the size of these channels. So that is how increased transcytosis results in increased vascular permeability. Now, one thing you have to remember, although we talked about the different mechanisms of increased vascular permeability separately, in reality they are more complex, and in most cases all probably contribute in varying degrees at the same time. So always keep that thing in your mind. So this concludes our first video on inflammation. I hope this video was helpful. If you like my videos, do comment, share, subscribe, and let me know. I will try to upload the second part of inflammation video, hopefully within a week, where we will talk about the cellular events of inflammation and also about chemical mediators of inflammation. I will also recommend my students to go through your textbooks to know more information. So, that's all for today. Until next time, take care and stay blessed. Thank you.